My name is Cynthia Patipati, Assistant Professor at Loyola University Chicago and Director of our Psychiatric Mental Health Nurse Practitioner Program. I am the moderator for the session entitled The Changing Face of Suicide, African American Youth. I am delighted to introduce Dr. Tammy Benton from the Children's Hospital of Philadelphia. She is the Executive Director and Chair of the Department of Child and Adolescent Psychiatry and Behavioral Sciences. Dr. Benton's research and clinical practice focuses on depression and suicide, including youth from racial and ethnic minority families. We welcome her expertise and wisdom here today.
Thank you, Cynthia. And I'm so happy to be here with all of you today. I'm going to pull up my slides. Oh, okay. I'm going to share my screen. So what I'm going to talk to all of you about today, I'm glad that I can join you. Chicago was where I used to live before I moved to Philadelphia, so it's sort of like coming back home to my tribe. But I want to talk with you a little bit today about what we're learning about Black youth and suicide risk. And what you're likely to find yourself saying at the end of this presentation is that you're surprised, in part because historically, our conventional wisdom has been that Black youth are at low risk for suicide. And I think we all believe that for many, many years. But what our recent data is telling us is something very different. For many years, it was probably the case that rates of suicide among Black youth were lower. But between 1980 and 1995, that really started to change. And it changed pretty significantly without much attention. I'm going to talk first about Black children, and then we're going to talk about Black adolescents. And this is a picture of my collaborator, Dr. Stacy July, who does a lot of work with younger kids and who helped me put together this presentation. When we look at the data around suicide rates, and I know you've seen a lot of graphs today, so I'm not going to spend much time on this one. But if you'll notice that the rates of suicide are, as we expected, as you've heard many times today, increasing among older adolescents, which we're defining in this group to be 16 to 18. For younger adolescents, the suicide rates are also increasing, as you can see on the second line. But if you look at the group among the 5 to 11-year-olds, you really don't see much of a change. And we've been operating with that idea for quite some time. But what we discovered is that graph was actually very misleading. What was actually happening between this time period of 1999 to 2012 was something very different. When we took a deeper dive into the data that we were examining around suicide rates, what we discovered is that there actually was not a decrease in rates for everyone, or that there was a flat line for everyone. What we were seeing were diverging trends. So that as the rates of suicide, as you can see in 1998 to 2002, were declining for white boys, they were increasing for Black boys. And as a result, the line looked flat. But if you looked a little bit deeper, what was happening were widely diverging trends in suicidal behavior among Black boys when compared to white boys. What we were actually saying was a fairly stable rate with a decrease among white boys and increasing rates among Black kids. That was very much of a surprise and not what anyone expected. And furthermore, we knew very little about the population of youth who were actually making suicide attempts between the ages of 5 and 11. In line with better understanding these trends, Dr. Sheftow's group, who was part of the last group who identified the trends, started to look at comparisons of young suicide completers compared with young adolescent suicide completers. And the reason that the group used those two comparison groups was related to the fact that we didn't have any information about the younger kids who were making suicide attempts. And it sort of made sense to compare them to a reference group about which we had much information. So as most of us know, most of the suicide data we have on young people really is on adolescents between the ages of 12 to 19. What we learned about the younger group between the ages of 5 to 11 is when compared with early adolescents, there were some notable differences. One of those differences had to do with the fact that the younger children from 5 to 11 were more likely to be male, they were more likely to be Black, they were more likely to die by hanging, strangulation, or suffocation, they were more likely to die at home, and frequently the precipitant to the suicidal activity frequently involves some problems in their family relationships or in their interpersonal relationships with friends. And then they were much less likely to exhibit depressive symptoms or to leave a note for their family members. Okay. And what are we seeing with Black adolescents? What we're seeing with Black adolescents are also somewhat surprising. And so when we look at the trends from 2009 through 2019, you'll see three curves, one for Latinx youth, one for Black non-Hispanic youth, and one for white non-Latinx youth. And what you'll notice is that the rates for the white population stayed roughly the same between 2009 and 2017. But as you can see in 2017, the rates started to increase slightly for Caucasian Americans again. And if you look at the Latinx population, we actually see decreases in trends of suicide for Latinx youth or suicide attempts for Latinx youth. But that's not the same for African American youth. What you see is a continuing upward trend of suicide attempts among African American youth. And that has been a shift. Well, I shouldn't say that's been a shift in recent years. It's become a notable shift in recent years that we've become more aware of. If we look at kind of what are the characteristics of African American youth or Black youth who are making suicide, and what are we seeing that was different? We looked at the trends overall between 1991 and 2017, and what we can see is that Black adolescents had increased rates of suicide attempts while rates declined for other racial and ethnic groups. So it wasn't just Caucasian youth, it was also Latinx youth. When looking at the data from the Youth Risk Behavior Surveillance Survey, which many of you are familiar with, it's the CDC survey that's completed every 2 years for high school students across the United States, where they ask them questions about health risk. So this is a non-clinically referred high school sample. They found that there were changes in the trend, there were significant changes in the trends, that Black males were making more attempts, that Black boys who made attempts suffered from more significant injuries than non-Black boys who made attempts, and that we were starting to see that Black adolescent girls experienced a significant increase in suicide attempts, while girls from other races and ethnicities showed declines in the rates of suicide attempts. Another finding that was very curious from these same studies is that Black male students had the lowest prevalence of suicidal ideation. So when students were asked if they had experienced any suicidal ideation in the last couple of months, the answer for Black males was most frequently no. But when we looked at students who had the highest prevalence of attempts, what we discovered is that the Black students that had the highest rates of attempts, though they were endorsing lower rates of suicidal ideation. So this was actually really quite surprising that Black adolescents and Black children had been making fairly significant suicide attempts, but it actually was not on the radar screen from a national perspective, and conventional wisdom around who was at risk really hadn't changed very much. But if we just look at these studies, from 1980 to 2017, what was glaringly clear is that the suicide rates for Black youths had been increasing for many, many years. So the fact that Black students or Black youth were killing themselves at high rates between 1980 and 2017, and we didn't really notice it, is really quite striking. Between 1980 and 1995, there was a 114% increase in the rates of death for Black youths to suicide. And then every study since then has shown an increase in suicide rates for Black youth and decreasing trend among Caucasian youth, which identifies a fairly significant disparity in our surveillance of suicidality among Black youth, which of course leads to a deficit in our ability to identify and intervene. So in line with that, I just want to highlight that our failure to recognize and or to highlight what we recognized and thinking about our suicide prevention efforts have really left us with a gap in knowledge about risk and protective factors. My colleague, Dr. Rhonda Boyd, does research in this area, and we're focused very much on looking at research opportunities to identify what the risk and protective factors are for Black youth. The recent data that I shared with you was also shared nationally, and Congress became involved. So Representative Bonnie Watson Coleman commissioned a Congressional Black Caucus to establish an emergency task force on Black youth suicide and mental health, of which Dr. Rhonda Boyd was a participant on the research subcommittee. And what was striking was that there were these recent identified increases in suicidal behaviors, but there had been no research focus and there had been no clinical focus in identifying the at-risk population and looking for solutions to address those risks. From that particular discussion, there has been a lot of focus on beginning to think about how we can identify factors that are risks for Black youth. And within the context of that work group, they were able to start to look at all of the literature on suicide prevention or suicide identification, and to start to begin to focus on which risk factors or protective factors were specific to Black youth. And what I want to spend some time on today is talking to you about some of those things and sharing with you what we know. And highlighting for you the gaps around information that we still don't have as it relates to Black youth. Some of the risk factors I'll talk about today are not just specific to African American youth, they're specific to all youth. But I'm going to focus only on those factors that have been demonstrated to have a link to suicidal behavior and attempts among Black youth. And so when we look at all of the risk factors that are identified as risks for suicide, depression, is a very common risk factor for suicide among Black adolescents, not so much Black children. The presence of externalizing behaviors, which are really the behaviors that typically bring Black youth to clinical attention. The presence of poor family support, the presence of a substance use condition, and or a diagnosed mental health disorder, either in the young person or in their family members. Additional risk for youth suicide for Black youth are the presence of mental health conditions in the individual in their environment, and the neighborhood context, which is really, really an important factor. And we'll talk a little bit about that later. Racism and discrimination has been identified as a factor increasing risk for suicide. And then sexual and gender minority status for Black youth is a significant risk factor for completed suicide. Now, I wanted to actually just tell you a little bit about kind of what we're learning from Black youth about their experiences of depression and suicidality and living in impoverished neighborhoods. There's a huge body of literature that is has very strongly connected the sense of living in an impoverished community with the experience of impaired mental health. And for Black kids and for white kids living within the same community, differences in socioeconomic status contribute to fairly significant differences in that experience. This is an excerpt from a qualitative study by Alfanedu and colleagues, looking at the experience of depressed Black youth living in urban settings. And I just don't think that anything could capture that experience for these youth the way this does. For adolescents, being depressed means experiencing high levels of violent crimes in your neighborhood. It is losing neighborhood trust and a sense of connectedness to your physical environment. It's living under stress without support and resources. It's not being able to go outside and play, visit your friends, or enjoy activities of interest. It is feeling unsafe and without protection where protection is expected. And most of us would expect that youth having those experiences would be more likely to experience mental health conditions. But interestingly, when we think about our assessments for suicidality, we rarely ask questions about the conditions under which young people are living. Another factor that's come to the attention recently, particularly in light of the events of the past year, has been the role of racism and discrimination in impacting the mental health of Black youth. And several recent studies and an increasing body of literature has focused on the impact of racism and discrimination on Black youth's mental health. But interestingly, there's a growing body of literature that describes a relationship between the perceived experience of discrimination and suicidal ideation. And so that there are studies that describe a strong association between perceived discrimination and increased suicidal ideation in Black adolescents, in addition to adverse impact on their psychological health. When looking at the frequency of racial incidents, the literature clearly describes fairly frequent experiences of racial discrimination for Black adolescents. In a study by English and colleagues, adolescents who were interviewed reported that they averaged over 5 racial discrimination experiences per day, including microaggressions and at times blatant macroaggressions. And we've also come to recognize that for African American youth, that many of the youth report that the experience of watching the events over the summer, watching other black men being arrested or beaten online or on TV contributed to significant post-traumatic stress and depressive symptoms. And so there are many opportunities for Black youth to be exposed to negative racial experiences that impact their mental health. As I mentioned a little bit earlier, another group that has been identified as being at particular high risk are those groups of Black adolescents who experience intersectionality. So for those who are sexual and gender minorities, in addition to being racial minorities, have an increased burden of discrimination that impacts their mental health. In a survey that was completed by, by the students, the Children's Health Research Fund, that interviewed over 1,600 kids with a large percentage of African American kids, they actually discovered that about 90% of them reported experiencing racial discrimination. About 30% identified experiencing physical harm or physical threats because of their gender minority status. And about close to 70% had reported that they had been verbally abused at some point, in their lives because of their gender and their racial identification. Other research has looked at the impact of adverse childhood experiences, or ACEs, on Black youth. And the data around ACEs and African American youth are pretty clear that Black youth under the age of 18 are much more likely to experience adverse childhood experiences than the broader population. But when looking at Black adolescents specifically, they were more likely to experience economic hardship at about 37%, to experience parental separation or divorce, parental incarceration, and family violence in the home. All of those are known to be risk factors for poor mental health. Okay. Now, I wanted to shift gears a little bit because we've been talking about broader populations, many of which are non-pathological or non-psychiatric populations. I did want to focus on some of the few studies that had looked specifically at populations of Black youth with mental health conditions. And I have to tell you, there really are not many. But in the samples that looked specifically at factors that impacted Black youth, there was one study by Merchant and colleagues back in 2009 that looked at a matched sample of Black and white adolescents who had been psychiatrically hospitalized. And they asked very specific questions, looking at what are factors related to psychopathology, social support, and interpersonal attributes that might distinguish youth who had made multiple suicide attempts versus youth who had made a single suicide attempt. And they wanted to break those groups out by Black compared with white youth. What they learned is that for all groups who had made multiple suicide attempts, that both Black and white adolescents identified that they all suffered from some perceived lack of social support. And that was consistent across groups. And that distinguished those groups from those kids who had made one suicide attempt. But among African American youth or Black youth who had made multiple attempts, what they identified that separated them from Caucasian youths were a higher sense of interpersonal orientation. So their interpersonal relationships with family and friends had very high value for them. And social comparison, being with people who were like themselves, and positive stimulation from those interactions were very important. When those relationships became damaged, or when those relationships were perceived to be impaired, Black youth were much more likely to make multiple suicide attempts when compared to Caucasian youth. In looking at studies for family factors and parenting practices for Black youth with depression and anxiety, there was one strong study that looked at parenting practices as they related to changes in depression and anxiety for Black youth. And what they discovered is that for Black youth who were presenting with depression and anxiety, that positive parenting was associated with a decrease in anxiety and depressive symptoms, that parental monitoring was associated with a decrease in anxiety and depressive symptoms. But interesting, psychological and behavioral controls were not associated with changes in depression and anxiety, which has been found to be positive for some Caucasian youth. In the studies of protective factors for African American youth, the things that have been identified most consistently in the literature are strong family supports and strong familial supportive relationships, a sense of belonging to a religious or spiritual community. So participation or membership in a church or having some kind of spiritual engagement was found to be supportive for Black youth. Community and social support. So being in a community of similar values, places where people felt included and a sense of belongingness was very important. And then when they looked at personal factors, Black youth who demonstrated positive self-esteem, who seemed to have a sense of emotional well-being and self-efficacy, Black adolescents who performed academically well did better than Black youth who did not. And then interestingly, for financial factors, stable family housing, stable income and employment were protective. But other studies examining middle-class African-American youth show mixed findings. So for middle-class African-American youth who actually live in primarily Caucasian communities, those kids tend to have more depression, more anxiety, and more suicide attempts than young people who live in Black communities with higher incomes. So the income itself is not the only factor that influences outcomes. More studies are starting to focus on ethnic and racial identity as a potential protective factor for African American youth. And when I talk about ethnic and racial identity, I'm referring specifically to a multi-dimensional construct. It's a psychological construct that reflects our beliefs and attitudes that we all have about our own ethnic and racial group membership. And that also includes the processes by which our beliefs and our attitudes are developed over time. And much of the literature suggests that having a strong sense of ethnic and racial identity can actually serve as a protective factor for African American youth. So in one study by Tynes and colleagues, they did an online study. They did a study of adolescents who were using some online social chat sites where they experienced bullying because of their race and ethnicity online. And in a fairly large sample of adolescents, black youth who participated in these online services who had experienced bullying because of their race, what they discovered is that for those kids who were identified as having anxiety or clinical anxiety symptoms, that those youth were much less likely to experience an adverse impact of racial discrimination online when they had a strong sense of ethnic identity compared with Black youth who did not have a strong sense of ethnic identity, suggesting that in many circumstances, a strong sense of ethnic identity can impact mental health outcomes. So I wanted to make sure, so before we move on to ending this discussion, we're going to focus the end of this discussion more on risk reduction and assessment. And as I mentioned previously, the lack of notice that the rates of suicide were increasing for Black youth has really left us with quite a few gaps in our knowledge about how we identify Black boys specifically who are at risk. What are the factors that protect those youth from poor outcomes? And then what can we do from an intervention perspective that's effective? And so I want to talk a little bit about the limited studies that we have that address some of those questions. So this study looked at psychiatric emergency department visits between 2011 and 2015. And this study looked at data collected from psychiatric emergency departments across the United States. The goal actually was to understand trends of increasing numbers of young people presenting to psychiatric emergency departments with mental health complaints. And so essentially, what they noticed was a significant increase in the volume of kids who were coming into the emergency department. But as they looked at that data to understand what was prompting those trends, they looked at the demographics of young people who were presenting. And so what you'll notice is when you look at the first graph, the first graph demonstrates that, as we discussed earlier, a fairly stable number of young people between the ages of 6 and 11 who presented to the emergency department for care. And then, of course, there are higher numbers as the children become older. So the 12 to 17-year-old and the 18-year-old groups have larger numbers of kids coming into the U.S., into the emergency departments. Although, if you look at the 12 to 17-year-olds, there seems to be a larger increase than there is among the older age group. But if you break this down by race, what you'll notice is that there's a significant trend among the African-American youth to have higher rates of emergency department visits between about 2013 and 2015. You notice that around the same time, the numbers don't change very much for Caucasian youths. And for Hispanic youths, the numbers do not rise as significantly as they do for African-American youths, which is consistent with the trends we discussed earlier. You will notice that for female patients overall, there seemed to be an increase in the number of girls who were presenting to psychiatric emergency departments. And then, of course, as we see in the lower graph, the trends vary by age group. But what was interesting about this study wasn't so much the demographics of who was showing up for visits, it's what happened to kids before they left the emergency department. What they discovered is that there was about a 30% increase in all of their psychiatric emergency department visits during that time frame. But the largest increase was noted to be among African-American and Latinx youth, while white youth remained about the same. And so the investigators concluded that the changes in volume were primarily driven by youth of color. What was even more striking is the number of kids who were presenting with mental health concerns increased by more than 2.5 for those who were presenting with suicide-related visits. And interestingly, despite the fact that the psychiatric visits were typically long, so the kids were in the emergency department for at least 3 hours, only about 16% of those kids were seen by mental health professionals. And for the African-American youth who came to the emergency department, the majority of them were identified as being non-urgent. That group was also identified as having public insurance, and they were much more likely to be identified as having a behavior disorder rather than an internalizing disorder. Now, that's actually important because that actually supports many of the findings that we've seen over time, that African American youth are much less likely to have follow up appointments. But what we're discovering is that more and more of the studies that look at this question have similar findings. So, for example, in a recent study by Fontanella and colleagues looking at young people who were psychiatrically hospitalized between the ages of 10 to 18 years, they looked at a Medicaid database. So all of the kids who were in this study were insured by Medicaid, but it was a large sample. It was close to 140,000 youth. What they discovered is that looking at the entire sample, for those who attended a mental health follow-up appointment within a week after discharge, had a significant decrease in their risk for suicide at 6 months. And a significant decrease was 50%. So it was about half, which is significant. They also identified that a little over half, about 56%, attended a follow-up mental health appointment within 7 days of discharge, which is actually what's recommended for kids being discharged from acute psychiatric care. But what they also discovered is that Black youth who were covered by Medicaid, individuals with a history of chronic medical illnesses, those who had engaged in self-harm, or those who were abusing substances, were much less likely to attend a mental health appointment within 1 week of discharge. That group of individuals are those who are at highest risk for completed suicide. And so the authors concluded from this study that access to care was a major factor impacting Black youth. In another study that I thought was interesting and not as well powered as the Fontanella study, did a latent class analysis to look at risk factors for suicide for young people. And this was part of the ED Stars project that Cheryl King has been managing for quite some time, where they looked at over 1,000 adolescents who had presented with suicidal ideation. And what they basically did is they took the symptom profiles of kids who could be identified as high risk, and they created profiles for 5 different groups of kids. And they wanted to be able to identify what the factors were that you might be able to pinpoint in groups of children coming into the emergency department that one were associated with elevated risk for suicide, but also associated with mental health services utilization. And what they discovered was very interesting. What they observed in this sample, which actually had a fair representation of African American students, was about 24%. They found that a higher proportion of Black youth had profiles that were characterized by a history of suicidal thoughts and behaviors and aggression, and that about 50% had profiles that included suicidal thoughts and behaviors. And that adolescents who had a history of suicidal thoughts and behaviors, and then a history of suicidal thoughts and behavior and aggression, were least likely to present to the emergency department with a chief complaint of a mental health condition, despite the fact they had reported a previous suicide attempt. They also discovered that the differences in mental health services utilization by race and ethnicity paralleled the distribution of these latent class profiles, such that the African American youth had lower mental health services utilization. And then, so the concerning issue, from my perspective, and one of the take home messages for me was that the risk profile for African American youth may look different. So there's under identification. And then if we use a go, no go triage screening, such as, are you suicidal today or this week? Without pursuing questions about past suicidality, you actually may miss a kid who's at significant risk. Now, in terms of treatment studies of African American youth, there are very few studies that have specifically looked at which of our treatments actually work for African American youth. There's only been one study that has demonstrated some efficacy for Black youth in treatment for mental health and suicidal ideation. And that study was not designed specifically to look at those symptoms in African American youth, but had a very large African American low SES sample. The sample was 66% African Americans. And what they found in that study was a multi-systemic therapy study, demonstrated that, that Black children did better after their MST intervention following psychiatric hospitalization and reducing psychiatric suicide attempts over 16 months. They also discovered that one of the factors that would contributed to decreased suicidal ideation was increased parental control as identified by the youth and the parents for 1 year before they returned to baseline. So the parents returned to baseline. What they also discovered is that there was no long-term effects on hopelessness or suicidal ideation, depression, or parental control. So I just want to summarize what we know about suicidality in Black youth is, actually not a lot. But we do have a lot of opportunities to learn a lot more and to focus more on this population. I think it's pretty clear based on the limited number of studies. What we know about the epidemiology is that it is a disparity, and a disparity that we have to address. What we can say, just to summarize, is one, we know that suicidality in Black youth has been steadily increasing. We don't know why, and we don't know how best to intervene. We know that there are very few studies that are focused on Black youth, and that the few studies that have focused upon risk reduction for Black youth, are not strong, and that there's been no studies of Black youth that have been shown to reduce risk for suicide. Two studies suggested some improvement in reductions in suicidal behavior for Black youth, and there were four studies that suggested that an intervention had some impact on suicidal ideation reduction. And attachment-based family therapy is the intervention that demonstrated those results. But what we do know is that not all the patients at risk receive the necessary resources. They don't receive them at the point of care. They don't receive them after discharge from psychiatric crisis. And this is especially true for minority youth. We also know that minority youth are often less engaged in traditional mental health services. There's some promising approaches, motivational interviewing principles to engage families in care. Care navigators. We're actually looking at culturally competent care navigators to facilitate connections. And then there's some data that suggests that matching clinicians by race and ethnicity can improve outcomes for youth. But we know that the chances of that happening for every youth is really not high. And so that the cultural competency is going to have to be a practice of all of us. But definitely more research and focus is needed to understand suicidality among Black youth and which interventions are effective for this particular population. And so that's the end of my presentation. And I think we should have some time for questions.
Thank you so much, Dr. Benton, for that wonderful presentation. I wish we had more time. There were quite a few questions that came through in the Q&A. The majority of them we will answer after. But I think the one question that many people had was, there was this discrepancy between the number of students, or sorry, not students, Black youth who reported suicidal ideation as compared to the number of attempts. So can you clarify what you think maybe is the reason for that incongruence?
Yes, that's a great question, and I don't know the answer to that. I actually think that our screening practices and the questions that we ask may not necessarily get at the kind of information that we want from kids. And so I think that, what we have seen in the data for Black youth is that frequently the suicidal ideation may have happened weeks before the time that they've actually been assessed in that particular survey. But many times the interviewers, even in the emergency department, ask about recent suicidal ideation. They don't ask about past suicidal ideation. And I think by failing to capture that, we miss a lot of kids who are at risk, because we know one of the strongest predictors for future suicidal behavior is past suicidal behavior. But I think the windows that we ask about frequently are not long enough.